Well, welcome everyone to the fetal acid-base status and umbilical cord sampling webinar presented by Dr. David Acker. Thank you for joining us. Today, Dr. Acker will be talking to you about his experiences and information on risks and safety issues related to this topic. Dr. Acker is the immediate past chief of obstetrics at Brigham and Women's Hospital in Boston, Massachusetts, and works with OB Consult, providing safety and risk management services to obstetricians, gynecologists, midwives, and OB departments. And with that, I'm going to quickly turn it over to Dr. Acker to get started on this topic.
Good morning, everyone. Thank you, Maggie, for asking me to make this presentation. I just wanted to start off by, after a career of getting things wrong at public speaking, I have come up with the following rules for myself that at least keeps people somewhat interested in what I'm saying. My intention is first to tell you what I'm going to do, and then I'm going to do it. And then when I'm done doing it, I'm going to tell you what I did, and then leave plenty of time to answer questions. And that seems to have worked out well for me, at least. Okay, so this is what I'm going to be telling you. That even though some may disagree, the consensus of opinions is that intrauterine events are causative of cerebral palsy in only a minority of the cases of cerebral palsy, estimated to be about 15%. If there is an intrauterine event, it doesn't come in some mysterious, silent way and impact upon the fetus without something pretty obvious happening. And we're going to look into what those obvious things are. We're then going to talk about the value of sampling the umbilical artery for umbilical cord gases. Again, the umbilical artery. Then, because not everything works in an ideal way in the operating room, I'm going to try and talk about what we can do if you can't get the samples, and talk about the validity of a delayed sample. And then last, you want to make sure that the sample has not been contaminated. And I'll go over some of the ways to at least be suspicious of your own results. Okay, that's what I'm going to do. And now, this is sort of a picture of the way I feel my dentist must look, and now he and I are going to do it. So I've put the reference for this, already 10 years old, but it's as good as it gets. The neonatal encephalopathy and cerebral palsy, put out by the American College of OB-GYN and the American Academy of Pediatrics, with a rigorous peer review surveillance at time interval, possibly some of the relatively firm statements that were made may be open for flexibility, but for the most part, this is the background information. And I will let you know, because there always is a medical legal aspect to what we're talking about. If the doctors and the nurses don't know this information in the next few slides, I can assure you the plaintiff's lawyers do. So it would be to everyone's advantage to get that treatise from the American College and stay up to date. The bottom lines are this. In 2003, the conclusion by the authors of this treatise felt that all 4 of these items needed to be present so that one could say that an intrapartum event, I'm sorry, if I said intrauterine before, I meant intrapartum event was present. And that is that there must be a metabolic acidemia. And the only way to know that is with an umbilical cord arterial sample. And I'll go over some of the numbers here in another slide. And second, the illness, which in this case had its origin in the labor, must show itself promptly. You can't have an APGAR of 9 and 10, a baby who does almost well for 6 years and then is diagnosed with cerebral palsy and say, oh, that's a labor event. That's just not so. The type of cerebral palsy is specific. And it would be prudent to exclude other events. Those 4 represent common sense, required items in linking intrapartum to cerebral palsy. There are other items that collectively suggest intrapartum timing. Some type of sentinel hypoxic event, usually demonstrating something dramatic on the fetal monitor tracing. A baby who has been, a fetus who has been exposed to these sentinel hypoxic events and demonstrated an abnormal monitor tracing should demonstrate in the immediate birth period the effect by having a low APGAR score. And it's not just that the brain is affected by this, but that this is a multi-organ system involvement. And sophisticated early imaging studies show diffuse cerebral abnormalities. So this is a reasonable obstetric goal. Don't deliver babies who are not acidemic. The fetus, the other key points are more biochemistry, but basically, what do we do? The buffers protect the fetus. The etiology of the acidemia, that is metabolic, is utero-placental insufficiency. There are other things that cause acidemia that are not metabolic acidemia, and we'll talk about that on another slide. At some point at our hospital, I tabulated the different ways at our hospital you could have a baby who was acidemic. And this will come as no surprise, although some of these, that splenic artery aneurysm, that occurred once in my 18 years as chief here, and often it is unclear, but these are the etiologies or the associated conditions that we saw at our hospital that we consider risk factors. Okay, what is the normal acid-base status? Well, I hope you can see this better than I can, but the normal artery pH pH of the artery is less than the pH of the vein. Completely different than in an adult. And the reason is obvious. The fetus's arteries drain into the placenta, which refreshes, so to speak, the blood chemistry. So the artery shows the effect of the metabolic condition of the baby. The placenta, so to speak, cleans it up. And therefore, it is important, if you're trying to assess the fetus, as opposed to assessing the placenta, to get the artery. That's going to be the message. You've got to get the artery. The vein is nice to get, but you've got to get the artery. Also, of note, the umbilical artery oxygen for the fetus is low. That would not be sustainable for an adult. And even the vein, after oxygenation has occurred from passing through the placenta, has what would be for an adult a deadly low level of oxygenation. And the reason the fetus thrives in that, for the most part, is the fetus has a different hemoglobin than adults and most children also do, and holds on to the oxygen differently. But basically, the fetus, there was an old phrase that the fetus is like existing at Mount Everest in utero. Something I remember one of my teachers telling me. So this is a study that looked at 30,000 live births. And about 10% of them, 3,500, a little bit more than 10%, had a pH less than 7.2. So the investigators here subdivided the blood, the fetuses, the babies, by those who had the various levels of pH. You can see that in the left column. And I only want to focus on the lowest, the less than 7.00. Because for the old-timers who are listening to this discussion, when we were young, the low pH was defined as less than 7.25. But that's almost a normal pH for a fetus. And less than 7.00 is the number below which people are saying this is potentially harmful acidemia. But you can see, even with a pH less than 7, only 10% had a low Acker. The neonatal death rate was low, and seizures were low. That's because most acidemia at birth is respiratory, usually due to cord compression, and that is easily reversed. Okay, how do you get the artery? Let me first of all say why it's important to do this. It is the most objective way of assessing the fetal metabolic condition at birth. You're able to distinguish between the more common respiratory acidemia and the metabolic acidosis or acidemia. The issue is, on the one hand, the more frequently you do it, and a few hospitals are actually having this done on every patient. The good news is, like anything else, the more frequently you do it, the better you're going to get at doing it right. The bad news is, who's going to pay for it? And if you wind up doing these analysis on every single patient, sooner or later the laboratory head is either going to thank you because the laboratory has now found a gold mine, but someone's going to complain, why did you do this? And doing it for practice is not going to go over well. Some hospitals still do it on every patient. We only do it when the 5-minute APGAR is 0, 1, 2, or 3. So here's the story. The artery reflects the fetal acid-base status. The vein does not. And you've got to have metabolic acidemia if you're going to infer that there was intrapartum asphyxia. The opposite is equally true, the converse. If you don't have acidemia at birth, this precludes acidemia as a causative factor. And a normal umbilical artery blood gas will serve as solid evidence long after everyone has forgotten what happened at that delivery. That one laboratory test is helpful. I would almost say it's crucial, but it certainly is very helpful. Okay, the trouble is this. The vein is easy to get, and therefore this useless or close to useless laboratory result is what is commonly obtained. It neither assists in the care, and it cannot ever be used to defend care. So here's what I suggest. If you're not sure, if you're looking at this picture, you'll see the juicy, large, easy to see blood vessel. That's the vein. And the little thin string of a blood vessel, that's the artery. So if you were a busy nurse in the middle of a C-section and the doctor throws you the umbilical cord, and the doctors still throw things in your hospital, and says, get the blood vessel, get the pH, and you're busy. The easiest, although useless thing to do is go for the vein. But you're wasting your time and everybody else's. If the vein is easy, then do it, but do it after you struggle to get the artery. Get the artery, the hard one, first. And there it is. I'm not telling you it's easy. I am telling you that the more you do it, the easier it gets. And if you're not sure which is the artery and which is the vein, although I have a lot of trouble figuring out why people aren't sure, because the easy one, the big one, the juicy one, that's the vein. And the hard one is the artery. So if it's easy for you to get, you're in the wrong vessel. So what do? If you just can't do it? Well, human beings being human, you can fake it. Just send one sample. Label it the artery. I'm telling you, it's happened in my hospital. I would never question the integrity of the person who did it, but after 18 years here, it's happened more than I would like to see. It won't work. You can't fake it, and I'll show you why later in this lecture. Send the vein. Hope for the best and give up. You might as well not waste your time. The best solution, if you're having trouble, is to tell someone, I'm having trouble. Now, if someone says, well, I'll help you out right now, that's great. Well, let's say everyone's busy. I'm having trouble. The cord is clamped. Put it away and wait for the case to be over when another person can help you. Let's see what happens. So the authors of this study were looking at singleton pregnancies, and they were looking at normal deliveries elective sections, high-risk patients. And for those of you who want to read the entire slide, you can take a look at this. But basically, they had about 30 patients in each group for a total of 90. And what they did was to take sequential samples. And so let's look at what happens if you can't get the artery initially. Or actually, let's say you did get the artery initially, and the artery in this case is all three of these, but let's just take from an elective cesarean delivery, that's the circle. The little square is from a normal vaginal delivery, and the triangle is from a high risk. If you were successful, all of the values were between 7.18 and 7.23, all of them. Let's say a half hour passed. So what's the change? The change is 0.05 to 0.07. So let's say you did it a half hour later, and someone else did it a half hour later to help you out. So you would just say, okay, I'm going to add 0.07 to whatever number I got. And that's what it probably would have been if I got it at delivery. I will tell you, I know it's an estimate, but it is a lot more valuable than sending the vein and then getting rid of the placenta or the umbilical cord. Nothing is as bad as just sending the vein. It's as good as doing nothing. Here, at least, you have an approximation. So that's the arterial pH. This gives you confidence that if you can't get anything out of the umbilical cord, go for the placenta artery. And you can always tell the difference in the artery goes over the vein. If a blood vessel is going over another blood vessel in the placenta, the one that's going over is the artery. Try and stick it and get a sample. But even a half hour later, you can see the change is very, very small. And you can wait a half hour and do it. Okay, let's talk about base excess for those who have not been chemists, so that everyone understands this. Let's say you had a sample of blood from anyone, an adult, a child, and you suspected acidemia. So you spin the blood down so the red cells settle down, and you have the serum, and you test the serum, and it's acidemic. And now you're back 50, 100 years ago, and so drop by drop, you drop in some base until you measure the amount of base that changed the pH to normal. That is called the base excess. So the more base you put in, the more acidemia you had. And the more acidemia that you had that was coming from a metabolic acidemia that had consumed base. Because respiratory acidemia does not consume base. So if you have an acidemia and you drop in just a little bit of base, or it wasn't very acid in the first place, this is a respiratory acidemia. The base excess, in the days when chemists would drop in things drop by drop, the higher that number, the more likely this is a metabolic acidemia. But you can see, even there, the cord and the placenta hardly change after a half hour. The bottom line here is there is plenty of time to get it right. And there are plenty of people who can get it right. And that's much better than your getting it incorrectly. And the same with the cord. Now the cord does change. The base excess does change more significantly here. But your key is going to be the pH. Same with the placental base excess. Okay. Whoop, I'm sorry. Got to go back. So let's just summarize. This is a good test. So often there's a question, well, what if I get this on everybody and it turns out to be abnormal for some reason? And then 8 years later, the kid has a learning disability. Is that going to hurt me? And I will tell you, after decades of medical legal consulting, I have never seen a pH to do anything but help. If the pH is really low and the baby is really immediately sick, the pH just confirms things. It's not a surprise test that bites you 10 years later. The most important thing is that this article provides data that says if you can't get it right, don't do it. Ask for help and get someone else to do it. Okay. Last, the sample collected from the right vessel can still be contaminated. Well, what can it be contaminated with? It's contaminated with air, contaminated, therefore, with oxygen. And, therefore, these authors had as their goal looking at the difference between growth restricted, that's the FGR, that's fetal growth restriction, and then the little b, borderline fetal growth restriction, comparing that to the appropriate for gestational age fetus, and then comparing that with the little b, that's borderline large for gestational age baby, with the large for gestational age. That's their interest. My interest is completely different. I want to just focus your attention on the average the birth weight appropriate for gestational age. And we're going to look at the differences between the artery and the vein and just how high blood levels can be before you have to admit, I got a contaminated specimen. So we're not going to focus on the growth restricted and the LGA, the large for gestational age babies. We're going to focus only on the appropriate for gestational age. And let's see what we can take from this author's work. Okay. In the middle column is the appropriate for gestational age baby. And on the top row across is the oxygen level in the cases they had, and one standard deviation. So 28.3 plus or minus 6.7. And below that, that's the vein, I'm sorry. And below that is the umbilical artery. And you can see that the oxygen level there is 15.7 plus or minus 5.3. Let's just look and see what the authors found. Let me go through with you what this slide shows. On the left side, you're looking at oxygen levels. On the bottom is the umbilical artery. Those are the 5 categories that the author was looking at. But look at the middle line. The middle line on the left side are the oxygen levels from the umbilical artery. Right above it are the oxygen levels of the umbilical vein. there is hardly any crossover in this diagram. Now, if you look at the standard deviations, you will detect that every once in a while there can be some crossover. But let's just say it's highly unlikely. You can tell that for an average umbilical artery oxygen level, getting into the mid to low 20s is exceedingly uncommon. So if you do the sampling and you say, oh, I think it's the umbilical artery, but the oxygen level comes out at 30, I'll tell you I don't think so. If you tell me I'm sure I got the umbilical artery, then I'll tell you it's a contaminated specimen. Let's look at on the right side, the carbon dioxide. Here, the top is now the artery, and the bottom is the vein. So again, in that 5 groupings, we're only going for the middle grouping, the appropriate for gestational age. And you can see again that the umbilical arteries, carbon dioxide, hardly ever overlaps the umbilical vein. So once again, you can tell which blood vessel you really got, and whether you can count on the specimen you sent by looking at the artery, or looking at the specimens PO2 and PCO2. If that's not clear, please let me know in the question, because I can't really talk to anyone during this discussion. So I'm making an assumption that I'm being clear, but it's only an assumption. Okay, here is pH. It's the same thing. The pH of the artery, again, looking at the middle sample, the appropriate for gestational age, there is not going to be an overlap in these cases. Okay, so I told you what I was going to do, and then I've done it. Now I'm going to tell you what I did. Intrauterine events as causative of cerebral palsy, metabolic acidemia is a requirement. Sampling, if you don't get the artery, the task is not done. What if you can't do it? Wait. Wait till someone who can do it comes around. How do you tell if your sample is contaminated? There is just so much oxygen that can exist in fetal arteries. If you have too much oxygen, it's either contaminated or it's a vein. All right. Time for questions.
Well, thanks, Dr. Acker. We do have plenty of time for questions, so if anyone has any questions, please recall the process. You can ask questions by clicking on the orange box with the little white arrow at the top right-hand corner of your screen. A box will come up like you see on the slides, and you can type in your question and hit send, and it'll be in our queue. And we actually have a few questions already in the queue, but welcome more. Dr. Acker, the first question for you is about the area of the program where you talked about the delay in taking the arterial cord blood gas, umbilical cord blood gas, and whether it would make sense to assure that if someone is taking a delayed sample, that they document that it was a delayed sample and document the time that the sample was taken?
Yes, and obviously the time of delivery, right, so that you can look specifically at the interval and try and do something better than just estimate the 0.05 or 6 decrement that occurred. On on average, these delays take until the case is over, and people are more available, or the pediatricians can help. Each hospital has a different system. Most hospitals, the nurse does it. And in most of these low APGAR babies, the nurses are busy taking care of the baby and the mother. And so, and that type of busyness is not necessarily translated into you got to get it the minute the doctor gives it. You could tell the doctor, hold your horses, Mac. At least that's the way the nurses in our hospital talk. And I'll get it for you in a half hour because Dr. Acker gave a lecture.
Very good. Now, related to that question, there's a question about how long after the delivery could a sample still be valid? What if it's as long as 30 minutes?
For definite, 30 minutes is not too long.
Okay, very good. Another question, at your facility, are there any considerations other than the APGAR at 5 minutes? Then I think you said 1, 2, and 3, for whether or not you collect cord gas specimens?
We have about 8,000 deliveries a year, and the decision for 0, 1, 2, and 3 was based on, as opposed to doing it on everyone, it was a cost question. No one would approve doing this on 8,000 patients. The lab wasn't going to give away the test for nothing, and we couldn't justify doing it to APGAR 10 babies. And most babies are APGAR 7, 8, 9, 10. On the flip side, once you go above, in 18 years of chairing these committees, the, quote, action, unquote, is with the 0, 1, 2, and 3. If you've got the people power to analyze cases with APGAR 4, go for it. But for the most part, the areas in which policy changes can be made to improve systems is with APGAR 0, 1, 2, and 3. So our risk management company requires that. And beyond that, it's individual judgment. Okay, got it.
The next question, going back to the area of the delay in sample taking, there's a question about beyond whether they're, regardless of whether let's say the sample was taken at appropriate timing and there was no delay from that perspective, but that there is a delay after the sample is taken to the time it gets to the laboratory. For example, someone indicates that oftentimes after delivery the sample is placed on ice and not sent to the lab right away for different reasons. Does that timing affect the sample in any way?
Okay. Not as much as the thing just sitting there. Once it's in the syringe, it has a stability that it doesn't have when it's in situ, in the cord or in the placenta. And the putting it on ice in a syringe and waiting a half hour is better than waiting a half hour and not doing it. So in many hospitals, you can't get to the lab immediately, but in the usual amount of time that it takes in the syringe, there's not a problem.
Yeah, and someone raised an interesting point and is looking for your commentary on it regarding this issue again. Is the solution to draw the arterial gases but only send them to the lab if it's needed? That way nursing does get the experience of obtaining the arterial gas, but you don't run into those cost issues you mentioned.
Tell that person I want them to send their application for admitting privileges to the Brigham right now. That is an incredibly clever, and I'm embarrassed to say I didn't think of, God, that's great. You get to practice, but you don't, It's a great idea.
Yes, I agree.
Give that person 10% off on their insurance, Maggie.
Well, Dr. Acker, I think there's another interesting question for you. Is it beneficial to obtain and run both the arterial and venous cord blood sample so that you can be sure that, in fact, you collected the arterial blood sample?
Yes. If you can get both, send both, because that is the 100% assurance that the one with the lower oxygen is the artery. No argument about it once that's done.
Well, great. I have a few more questions, and then I think we'll probably be wrapping up unless more come in. But let me ask you, what is the most frequent error that you have seen over time as it relates to collecting the umbilical cord blood?
Inexperience, fatigue, stress, impatience, and the nurse being hounded by the doctor to do 3 things at the same time. Get the blood sample, and come back here and help me count the insulin. It's the hounding of the nurse to do more than a human being can do. And then it's inexperience, stress, and fatigue.
And you may have already answered this next question. Why does the vein have higher levels of oxygen than the artery? Isn't it typically the other way around?
Yes. In Maggie, in you, and in me, and in the questioner. But let me try and clear it up. Let's just take us. In our arteries, the blood has just come back from the lungs and has gotten a blast of oxygen, and now the arteries from the left atrium of the heart, the pulmonary vein brings the blood to the left side of the heart. The left ventricle pumps it out the aorta. It goes into arteries, and it is fully oxygenated. Meanwhile, after the organs use the blood and the oxygen, things return to the lungs via the veins. The inferior and superior vena cava drain into the right side of the heart, which then pumps it to the lungs. It's the lungs that are the refresher organ, where the carbon dioxide is exhaled and the oxygen is taken in. Well, the baby isn't breathing in utero. The baby is using his or her placenta. Well, not the baby, the fetus is using the placenta. And therefore, the blood coming from the umbilical artery is going to the placenta to get refreshed. Then it comes back into the fetus by the umbilical vein. And that's why the vein has more oxygen. It just exited the placenta, which for the baby is the baby's lungs. You get that, Maggie?
I do.
And we'll just assume so have all the doctors and nurses.
All right, well, here's another. There are a few more coming in yet, and we still have time. So,
good.
One listener is interested in you're confirming this statement that the diagnosis of metabolic acidemia via a venous sample is void.
Yes.
That's a true statement.
It's true.
The last question we have, we have 2 more. One question is about the ice that someone mentioned.
Yeah.
The question is whether it's necessary to keep a sample on ice until it is received at the lab. Is that the proper process?
It is not necessary.
Okay. And then the final question, actually the final question you had already answered, so.
Well, try me again. Let's see if I give you the same answer.
question that you did answer before.
All right, Maggie. You don't want to test me. Okay.
So that's all the questions we have. We got done a little bit early. Thank you, everyone, for your participation, and particularly thank you, Dr. Acker, for your very detailed and enlightening presentation. And if anyone has any questions that comes up for them after the program, please feel free to reach out to us. Also, just a general announcement for everyone that we will be posting these slides and the audio portion on the OB Consult website at www.ob-consult.com so that you can have access to them. There were several questions about that. And we'll be circulating in follow-up information on our next scheduled webinar for the month of May in the short term, and we hope you can join us for that. Dr. Acker, any last comments?
I appreciate being asked to do this, Maggie, and I hope it was helpful to people.
Well, thank you very much, Dr. Acker.
Okay,
Everyone
bye-bye.
have a great day.
Bye-bye.